hierarchy is something, you hear about as a pre-med and you experience, I think, as soon as you start med school and get your short white coat. And the hierarchy can be difficult because depending on where you are, what rung of the ladder you're on determines when you speak, how much of a role you have in patient care. And I think what's been nice is over the past few weeks, the hierarchy, I think, is completely dissolved.
Hello everyone and welcome to Shrinking Burnout, podcast where two burnout shrinks, myself, Dr. Radhakrishnan, and my co-host, Dr. Roop, talk about clinician burnout. Today, we have a special guest for this episode, a psychiatry resident who has worked both in psychiatric and medical settings. Rohan will offer a unique perspective on how he's experienced working during the COVID-19 pandemic and his thoughts on resident wellness.
Rohan, thanks for coming on today.
Varsha and Andy, thanks for having me.
Rohan, why don't you tell the viewers a little bit about yourself?
Sure. So I'm a psychiatry intern and I work in one of the major cities in the Northeast. And as part of your first year of psychiatry residency, you do a few months of internal medicine. So currently, while I am a psychiatry resident, I'm actually working at a community hospital. And my primary focus right now is treating patients on the internal medicine side.
And Rohan, you actually have a pretty interesting perspective because you're able to tell us a little bit about both working in the medical setting and both the psychiatric setting.
So, while there are a lot of similarities between psychiatry and medicine, I think there's some clear differences, and it's been pretty interesting experiencing both the psychiatry and medicine side of healthcare.
What's your day-to-day been like now at the community hospital?
Things are definitely different in the era of COVID. So for one, typically residents, we work in a resident workroom, which is nothing fancy. It's a room where all the residents work. But in the era, say that again?
Is there a coffee machine, Rohan?
Unfortunately not. It's just laptops and keyboards.
Oh, man.
I would say...
workroom.
Yeah, that would make the typical workroom. But in the era of COVID, we're actually working down in our auditorium.
Tell us a little bit about this auditorium setup you got there.
Yeah, so it's a large auditorium where they've installed desks with computers. And I think what's nice about it is it's just more open than a traditional work setting.
Is it for social distancing at that point?
It's for social distancing reasons. But what's interesting is moving forward, the hospital staff has been considering, maybe just having residents work in the auditorium just because the residents seem to prefer it since it's more open and it's just more palatable.
How many of you guys are in the workroom or in the auditorium?
There's four of us down there, so you can imagine.
It's really spread out.
In a 300-400 seat auditorium, there's four of us with 4 desks.
Okay.
And so what? Are you right now responsible for COVID patients, or is it split between different units? How's it working right now?
So when I first started internal medicine, my census was primarily COVID patients. Over the past few weeks, I've seen that the number of COVID patients has actually decreased, which has been something positive to see, and it's been helpful to sort of just see the number of new COVID cases slow down. So I would say currently my census is a mix of some COVID patients and some of the more just traditional patients who are on the hospital floor.
What's it been like caring for COVID positive patients?
Yeah, so I actually find that my experience in psychiatry as a psychiatry intern has been very valuable with COVID patients, at least in the hospital where I'm at. And I think most of the hospitals that I've heard, the treatment right now for COVID patients is primarily supportive. So, monitoring their vitals, giving them oxygen as needed. And so often I found that the most meaningful intervention is sometimes providing just that emotional and moral support, both for the patients and the family. And I think this is where my experience as a psychiatry intern has been valuable because I've really viewed my role as a liaison between the patients and the family. For the patients, I think that, they're isolated. We come in with masks. And so I try to give them some emotional support when possible. And for the families, I try to serve as their eyes and ears because they, in this era of COVID, can't physically see the patients. So I found that the most rewarding thing is really updating families, sometimes with the use of technology.
And what has been your direct role in terms of updating? Do you usually call families every day? Do you have like a video camera set up, like an iPad or something like that?
So that's a great question. Initially, I was calling families to give them updates. Over the past few weeks, I've actually been using iPads more often, and I think it's great. I think it's great we're in an era where we have the technology to do so, because I think it's one thing to describe a patient or a family member to another family member, but it's just so much simpler and more effective if I pull up FaceTime, bring the iPad into the room. It's as cliche as it is, when people say a picture is 1,000 words. I just find video conferencing to be so much more effective than phone calls.
Rohan, can you tell us a little bit about a situation where maybe the patients were particularly frustrated with just being in isolation, or if there are any sort of particular difficult interactions with family members caring for these patients?
I think one example that comes to mind is a patient in the hospital whose husband was in the hospital as well as her brother, and they all had COVID. And it was tough. And so you can imagine the son, I could really sense the son's frustration because every day was sort of a guessing game in terms of how his 3 other family members were doing. And while I was taking care of, one of the family members and was able to update him directly, I am not sure how much of an update he got about his other 2 family members. So that was really challenging to see. It's not an isolated example. I know of other patients who have had other family members in the hospital at the same time.
And so, Rohan, thank you for sharing that. It sounds like the experience of being a psychiatry resident has really, given some advantage or has become very useful in this setting to provide emotional support, as you said. But were there situations over the past few weeks where you felt either uncomfortable, or was there ever like a situation medically where you felt like, hey, I'm a little bit uneasy about dealing with this?
Yeah, I think, one of the challenges of medicine is as a hospitalist or as a medicine intern, you really are trained to sort of be a jack of all trades. One example I can think of is I had a really busy day where I had some COVID patients who were not doing well and were requiring increasing amounts of oxygen. So I was trying to check in on them pretty periodically. And at the same time, I had someone with atrial fibrillation and whose heart rates were getting out of control. And I, as a psychiatry resident, we have learned about AFib and we know about general management, but that day was particularly challenging because I found myself trying to be in 3 different rooms at the same time, managing 2 patients who were not doing well.
And were there periods when you felt either well supported, not so well supported by the community that you were in, like the other residents, coworkers, so on and so forth?
Yeah, it's been both. I think one of the challenges coming back to internal medicine as a psychiatry resident is that historically as an intern, you have a junior or senior resident to oversee your work, provide support, help you out. And in the era of COVID, the junior and senior residents who historically have supervised us have been pulled onto other floors. So right now, the structure of my team is just intern and attending only. That's been actually challenging at times, especially when you have a busy day and you have many patients who are struggling at the same time because you just don't have that additional helping hand. On the flip side, I would say that given that the teams are restructured, attendings have been, at least in my experience, much more supportive, much more accessible. And I think the general work environment, there's just more camaraderie and friendliness. I think my experience, as an intern or as a med student, there's a hierarchy. But I feel with COVID and with everyone being stretched thin, it's been nice to see people working together, even from different training backgrounds and experiences. And so I really view attendings now more as partners, and I feel like I'm much more willing to reach out to them for help.
Can I go on a tangent?
Sure.
And talk to you, Rohan, about the sense of hierarchy in medicine and how it's hard to, at least in my experience, when you're the medical student, when you're the intern, you're kind of the lowest person on the totem pole. I'm wondering if you could talk a little bit more about the hierarchy.
The hierarchy is something, you hear about as a pre-med, and you experience, I think, as soon as you start med school and get your short white coat. For viewers who are not in medicine, the hierarchy is really referring to levels of experience. And so progressively up are the interns, and then the junior residents, senior residents. Sometimes there's a fellow, and then the attending who's completed their residency training. And the hierarchy can be difficult because depending on where you are, what rung of the ladder you're on determines when you speak, how much of a role you have in patient care. And I think what's been nice is over the past few weeks, the hierarchy, I think, is completely dissolved.
And so I think you bring up a really interesting point about hierarchy. It sounds like the disruption or the dissolving of the hierarchy itself has made the work environment a little bit more comfortable. And so that brings up the question, does medical hierarchy in the hospital actually contribute to burnout? I mean, from my own experience, I certainly think so. As an intern, it's really hard. You're juggling so many different things. And over the past couple of weeks, actually, I've been subbing in for interns. And so it brought back memories. I was like, wow, I really worked a lot.
Yeah.
So it goes to show, as you keep advancing, you certainly have more experience, but a lot of the brunt of the legwork ends up actually falling to the people who are interns or junior residents.
To give a little context to the medical hierarchy, it really is a lot like that of a military institution, where there are clearly people who have less experience and have less input in certain patient cases. And I think historically it existed for maybe a well-intentioned reason, but it does have an unintended consequence of making those who are maybe less experienced and on the lower end feel a little less important and feel dehumanized in a certain way.
Andy, I think you bring up a really interesting point on the similarities between medicine and the military. One area I see this is really in terms of language. In the past few weeks, one of the terms that I've heard a lot is this term being redeployed. And that refers to when physicians transition from their home specialty to another specialty to help out. So, for example, being in psychiatry, moving to the ICU to help out there. We use the term redeployed in the military as well. And so I think as much as we might want to deny it, there are some similarities just in terms of culture between military and medicine that are undeniable.
No, absolutely. And especially the aspect of the rigidity of the hierarchy, I think is very similar between the two. And I do think there's a lot of detrimental things that come from the hierarchy with regards to the feelings of powerlessness or feeling less important on the team. There are, of course, points where people are a little bit more old school and we call it, it's a term in medicine that we call pimping, but it actually means asking questions. If any of you have seen Scrubs or Grey's Anatomy, it's when an attending physician or someone who's higher up than you constantly asks you questions. That's one way to learn, certainly, but there's negative ways to do that, which is putting a person on the spot, making them feel embarrassed, versus actually asking questions with the intent of wanting to teach or help that resident improve. This is like a really good example of one of the other cultural aspects that influences burnout. And so I have a couple more questions for you, Rohan. Are you personally feeling the effects of burnout right now?
I am. I would say while I've been trying to protect my mental health as best as possible, the aspect of burnout I struggle with most is isolation. I'm originally from the West Coast. Most of my family and some of my really good friends are on the West Coast. In the era of COVID, I think it's been compounding levels of isolation that have really stacked on top of each other, which has been hard to manage. And so socially too, with quarantine, it's hard to hang out with people, almost impossible. And then at the hospital too, as I was mentioning, there's that theme of isolation. Residents are sitting far apart. Teams really try to stay to themselves, and even patient care, we're encouraged to spend as little time in the room as possible. So I think when all these layers of isolation stack up, it can be challenging.
Rohan, you mentioned a good point about the isolation. Our previous guest, Sarah, also talked about how kind of the options of winding down when you get off of work are really limited in the era of COVID.
I think what's been challenging is some of the activities I enjoy doing are tough. And so one thing I really like doing is dancing. And dancing is a very social activity.
What's wrong with dancing by yourself?
I've been doing a little bit more of that.
Okay.
But I think some of the interesting things that I've tried to do to work around is actually I've been doing Zoom Bollywood workouts with my sister, her fiance, and my parents. So, you know, that's something that was born just through COVID. And we decided we all love dancing in our family, and there's Zoom. And why don't we combine them together and put on some music in the background? So that's actually been a lot of fun.
I think it's really important for all of us to still stay connected as much as we can. And so you've told us a lot about what it's been like recently working on medicine. What was it like on psychiatry?
Prior to starting medicine, I was on our inpatient psych unit right around the time that coronavirus was becoming more and more of a presence in the United States. And it was scary. I would say that on the inpatient unit I was working on, someone had contracted coronavirus. And by the time that we transferred them, several other patients contracted coronavirus as well. And you can imagine it's such a closed, confined setting, and it is actually the perfect place for something like a virus to spread. And so I think I started getting glimpses of telepsychiatry. While we residents were still physically in the hospital, we would be interviewing patients with an assistance of an iPad attached to a moving device. And so I think it was interesting because I think telepsychiatry is going to become a big part of our field.
Did you find that it was a rewarding interaction to have?
I think it was. I think it translated better than I thought it would. I think with psychiatry, while ideally being there with the patient is most helpful because there's so many subtle and nonverbal cues you can pick up in person, I did feel like I could do decent assessments just through talking with people over an iPad.
So you have the outpatient world, which right now it sounds like, most people who are seeing a psychiatrist are doing this through telepsychiatry. It seems like overall, the fact that we're still able to provide this service, it feels very valuable, especially as we continue to be quarantined for a longer period of time. And the other thing, just for our listeners to go over just the structure of what an inpatient psychiatric unit looks like. So regular inpatient medical units, you'll have, an individual room. Often it'll be either 1 to 2 patients in that room. They have their own bed, own section of the room. They'll have a nurse who's assigned to them to help take care of them, along with a medical team. But the patients in general, they may walk, in the hallways, but there's generally not much of a space to socialize or do any kind of group activities, anything like that, because it's primarily medical. In the psychiatric unit, on the other hand, it's almost like a dormitory. So patients will sleep in their own individual beds that are not hospital beds, actually. They look like just regular dorm beds. And then there's a lot of group activities and group therapy. So I think one thing that has been suffering is the group treatment, the group therapy in the milieu that has been impacted due to social distancing.
Agreed. And I think that's one of the most challenging things from the psychiatry side is, like you said, a lot of the programs we offer to patients, what group therapy, partial hospital programs, outpatient support groups, those have all been dissolved. And, there's been some virtual substitutes, but it's been really hard to find good outpatient supports for patients who tend to do well when they have others.
And I think it's worth really emphasizing that coronavirus and COVID-19 have really changed all of medicine, and a lot of specialties of medicine, not just psychiatry, are really shifting towards the telemedicine platform. For psychiatry, it's probably a little bit easier being able to assess these patients. Certainly we still have our limitations, but if you're imagining the primary care doctor who isn't able to take a vital sign or who isn't able to do an accurate physical exam. So these are other aspects or other specialties of medicine that have really been affected. There are other specialties where they've kind of been furloughed. They haven't been able to work. A lot of surgical specialties, their work has decreased a lot, and they haven't been able to operate because a lot of these surgical centers have shut down.
So Rohan, has there been a point where you felt like you weren't able to do enough or do what you wanted to do to be able to care for patients in the setting of COVID?
Certainly. I have felt, I think, what you could describe as guilt when I've dealt with some of my COVID patients, particularly the ones who haven't done so well and eventually had to be transferred from the medicine floor to the intensive care unit. And it's tough because during these times, especially with COVID patients, to protect the patient and to protect other patients as well as ourselves, we're instructed to spend as little time as clinically indicated in their rooms to perform our assessment. And that's been really tough, I think, as a psychiatry resident, where patient interview, patient rapport, the patient interaction is the crux of what we do. And so with some of these patients who have had to be transferred to the ICU, I found myself feeling guilty, wondering if I should have spent a few more minutes every day just talking with them, because while that may not have changed their course, it may have internally left them in a better place. And so that's something I definitely struggle with.
Rohan, what you just mentioned earlier about needing to minimize your time in a patient's room with the quality of patient interaction brings to mind something we talked about in the previous episode about moral injury and moral distress, where you know in your heart that you would want to do something to be able to talk to this patient for a really long time, but just because of something that's outside of your control, this virus and being able to protect yourself, you're kind of forced between a rock and a hard place, and there really is no good solution for you. And in the end result, you just sort of feel guilty or you feel bad about the situation.
That's true. And I think a word you said, Andy, really resonates with me, which is control. I think it's really important as providers to distinguish what's in our control and what's not. And I found that reflecting on that helps me tackle those feelings of guilt and negativity. And so I can't control when the virus is over. I can't control when quarantine's over. But if I focus on what I can control, and while I work within my limitations.
I think what you're saying, Rohan, is that you're working in a situation, and I think a lot of clinicians are working in situations like this, COVID or not, where there are just so many things that are outside of your control. And it's really easy to sort of get in the dumps and really worry about all these things that you can't really control. And sometimes it sounds like for you, Rohan, that being able to focus on the things that you're able to control makes for a better day for you. So now I want to take a little bit of time to talk about redeployment for both me and Varsha. So we're second year and third year psychiatry residents, and when it came to redeployment, there were a lot of talks in our hospital as to if psychiatry residents were going to get redeployed to a medical setting, like on the medical floors, the emergency room, or the ICU setting. And the reality is that there were talks, but none of it actually happened. During this time in which there was a lot of these talks, I think amongst ourselves and amongst the psychiatry residents, there was a lot of feelings of guilt, perhaps, in trying to decide what the right thing to do in a case like potential redeployment was.
I think one thing that was difficult for me was that my family often would call me, ask me how I'm doing. It felt like sometimes I was getting this accolade for something that felt almost undeserved. I think that underlying feeling of guilt was mainly with regards to me feeling guilty that I couldn't be there at the front lines with my internal medicine or emergency medicine coworkers, but at the same time being fearful and afraid of what would happen if I were to be on the front lines. I think those two things I was wrestling with led to a lot of internal struggle.
Yeah, and maybe it's worth talking about the broader picture of how COVID-19 is going to possibly change mental health and how psychiatrists are really going to tackle this issue.
I absolutely think that this period of time will be testing our resilience as a nation. And so on that note, I did want to wrap up. Thank you, Rohan, for being here and sharing your experiences and thoughts with us. You're coming from a unique position as someone who's working as both a psychiatrist and an internist during this period of time.
And Varsha and Andy, thanks for having me. It's great chatting.
And I also wanted to remind our listeners, we'd love to hear your thoughts. Please feel free to reach out at shrinkingburnout@gmail.com if you have any thoughts, questions, suggestions, or if you want to be interviewed on the show.
And stay tuned for our next episode where we're going to interview some medical students to talk a little bit about medical students and burnout.
Shrinking Burnout is a podcast about furthering the discussion of clinician burnout and recognizing the resilience and hard work that many clinicians regularly demonstrate. Nothing we say on the show should be taken as medical or psychiatric advice. All of the opinions expressed on this podcast are solely our own and do not reflect those of our employer.